Hello and welcome to the Intentional Clinician podcast. I'm your host, Paul Krauss, licensed professional counselor. In today's episode, I'm bringing you not one, not two, but three special guests from Sanford Addiction Treatment Centers. We are going to be discussing challenges in addiction treatment and substance use during a worldwide pandemic. Some of the topics we're going to be hitting are a heightened level of anxiety, alcohol and drug use, relapse and overdose due to the COVID-19 pandemic, the reasons behind the increases, the need for compassionate self-care, what Sanford House and other addiction treatment centers are doing, a lot of the problems and not a lot of solutions that we're hearing in the media, and the impact of telehealth on addiction treatment. Sanford Addiction Treatment Centers is a residential and outpatient facility located in Grand Rapids, Michigan. Sanford offers excellence in evidence-based practice models in a home-like restorative setting. The clinicians at Sanford Addiction Treatment Centers are supported by a medical team, and they focus on resolving the underlying issues that often cause substance use, such as trauma, unhealthy relationships, co-occurring disorders, and isolation. Programs include residential day programs, intensive outpatient, medication-assisted treatment, education, and relapse prevention classes, also including now telehealth and teletherapy, one-on-one and family therapy, as well as alumni and support for families with groups. I'm going to be bringing onto the show Ray Green, JD LPC CAADC, the founder and president of Sanford. Ray has dedicated her working career to chipping away at the shame of addiction. As Sanford's primary spokesperson, her goal is to provide education and awareness of substance use disorders. Ray is a featured expert at conferences, in the community, and in the media. Her philosophy at Sanford is to provide evidence-based practices, medication-assisted treatment, and a continuum of care in a comfortable setting where healing and a sense of rekindled worthiness is achievable. Lynell Brewster, registered nurse, LPC, LLMFT, CCTP, clinical director, therapist at Sanford. Lynell has been working in the health field for the past 24 years. She is a registered nurse and a licensed professional counselor. Her experience includes working in hospitals and home settings, residential, outpatient treatment centers, and private practice. As clinical director, she works with Sanford clinical and medical staff administering all aspects of group, individual, therapy, and other treatments. This includes residential day treatment programs, residential treatment, outpatient programs, family and alumni programs, and virtual telehealth and care. Marilyn Spiller, Director of Marketing and Editor-in-Chief. Marilyn has been a marketing professional for more than 20 years, most recently in the addiction field. 7 years sober herself, she penned one of the first sobriety blogs, Waking Up the Ghost, starting in 2013. The blog garnered an international following. As Sanford's Director of Marketing, she is responsible for publication, research, branding, outreach, website design, and search engine optimization. She also manages Sanford's online magazine called Excursions. All right, I hope you are really going to love this episode. I loved interviewing these three amazing women, and the Sanford Addiction Treatment Center is my number one choice for people in the Midwest so far for going into addiction treatment. I've toured the facility. It is excellent. They really get trauma, and they really know what they're doing. So without further ado, here is the interview. All right, I'm so glad to have on the Intentional Clinician podcast the Sanford House Addiction Treatment Center's leadership team. And as you've heard, I read the bios earlier, but Ray Green, Lynell Brewster, and Marilyn Spiller, welcome to the show.
Thank you.
Hi, Paul. Hi, Paul.
Hi, I'm so glad that we could do this interview during the quarantine that's continuing, thanks to Zoom and all of that. So I'm excited to get into the topics today. We're talking a lot about challenges in addiction treatment, especially considering all of the stress and different challenges of COVID-19 in 2020. And we're going to go into a lot of discussion about that, as well as solutions and what we can do to help. And also, we're going to talk a little bit about telehealth and how that's changing the landscape a little bit. So, we've introduced Sanford House so people know a little bit about what you guys are up to, but I wanted to talk first, get all three of your takes, because you all have three completely different backgrounds. So I kind of want to get all three of your takes one at a time about the heightened level of anxiety alcohol, drug use, relapse, and overdose we're seeing due to the COVID-19 stressors that are emerging. So who wants to tackle that one first?
I can start with a few comments, Paul. This is Ray. And we're seeing, due to the pandemic and quarantine, a surge in demand for services. But in addition to that surge, we're also seeing people who are in a much more advanced state of crisis. So the disease process is happening in isolation while people are in quarantine. So we're seeing a heightened level of desperation amid this crisis. And I think the discussion will take us into more details about why. But our admissions phone line has really become a hotline of sorts. People calling in for family members, for themselves, not really knowing where to start, looking for help in a much more desperate fashion than we've seen before.
So right on the front lines, you're already just sort of seeing the anecdotal evidence of what we're starting to see in the statistics, which is almost too soon to tell, but there's already an uptick
Absolutely.
in addiction, people reaching out for help with addiction and in a more severe state. And so I'll just mirror that before I ask Linnell about her interpretation of why, and then go to Marilyn. But my theory so far is that when you're in isolation, and we see this from different studies on loneliness and isolation, that whatever people's chronic underlying stressors or issues may be, seem to come to the fore when you aren't in a routine or around friends and family as much, or different, and having different opportunities. So there's this sort of like isolative effect. And then I think, as we see in our culture, coping by drinking or smoking or using drugs and alcohol and whatever has already been a thing in our culture for, since America started. And now, that's a go-to. And we're actually seeing, and I read the other day in the newspaper that in Michigan, here where we are, and across the nation, alcohol and marijuana sales are skyrocketing to levels never before seen. And they're mostly take-home sales. So not even the bars, just going to the store. And in Michigan, of course, marijuana is legal now. So marijuana is, the recreational sales are up, not just the medical sales. So, Linnell, I wanted to ask you a little bit about the clinical perspective of what you're seeing and what you think some of this heightened level of use and people getting into an addictive pattern. Why do you think that's happening?
Yeah, on the front line, as I'm in the houses every day, just talking with clients as well as telehealth, we're really finding that one of the main themes, as you've spoken about already, is the isolation. And that has been the reason for many coming into treatment, and for many clients that have relapsed that were doing well. They had their setup of community support, and all of a sudden, a lot of that went away. And so we are seeing that throughout both houses, the isolation, the extra stress of having to homeschool children, loss of jobs, worrying about finances, how am I going to pay my bills? Just all of those uncertainties heightens what they're dealing with already with the addiction. So that's one of the main things that I'm seeing with spending time in the houses and talking with the clients.
Yeah, so it seems like even people that were in a good spot who had been, in recovery and doing a good job, all of a sudden, all of these different stressors and patterns of life drastically changed in a few months. And then this caused what we see in addiction is relapse. And relapse can be a quick thing sometimes when you're in recovery, but sometimes relapse can become dangerous and go back into full-blown use. And that's probably why some of the people are coming into intake, is that it may have gone back to the severe type of relapse. Is that what I'm hearing?
Yes, absolutely.
So, yes, I think it sounds like we're seeing some of the same things. And Marilyn, if you could kind of share your perspective a little bit on this, that would be wonderful.
Okay. As I guess the main thing to say is that I wear, as relates to this conversation, I'm wearing two hats. One is the marketing director of Sanford, the other is a person in long-term recovery. So I look at it from a couple of perspectives. I keep a lot of track of a lot of statistics, and as you mentioned, Paul, there are, every marker that can be tracked right now is showing that everything having to do with anxiety, addiction, chronic pre-existing issues like OCD, suicidal ideology, all those sorts of things are on the rise. Even social media indicators are showing that there's a rise in hashtags with with titles like depression and anxiety. There's a surge in EMS responses for opioid overdoses, and an increase and potential for a large increase in opioid related overdose deaths. So there's all that going on. But as a person in recovery myself, I've been over the last 6 months really sort of analyzing all of this. And from my perspective, it comes down to two things, really. One is what everybody's already talked about. That's isolation and all of the exigencies associated with isolation. As a person in recovery, I was always told that the opposite of addiction was connection, that community was all. That isolation was very bad for a host of reasons that Ray and Linnell as therapists can speak to. And here we are in a situation where we're being mandated to isolate. That word was specifically used at first, and then they changed it to distancing, probably because of people like me writing opinion pieces for newspapers. But so isolation is one thing. And then the other is the concept of motivation. I mean, more than anything else, I wouldn't say my recovery's been tested or tried during this period of time. I think everybody's experiencing the same issues associated with uncertainty and anxiety and loneliness. But people in recovery, particularly new to recovery, are a vulnerable population because, and I can say this as someone in recovery myself, we're always looking for a loophole. And boy, is the pandemic the ultimate loophole. So we just published an article by one of our therapists, Allie Kitchen, where she talked about the difference, particularly as relates to the pandemic, between motivation and discipline. I can be motivated to quit drinking because my husband's going to leave me if I don't, for example. But motivation waxes and wanes, sort of like the weather, or in this case, the pandemic. And so if you don't have that discipline in place, and again, this is something I'd love to hear Ray and Linnell speak of, but your sobriety, your sober tools, your recovery support system, and all the things that you have in place, how you identify yourself as a person in recovery, you've got to be able to pull on those things in spades, because one of the issues has been that typical support systems like 12-step meetings, and group therapy, which is the sort of cornerstone of addiction treatment, has changed to telehealth. So, the bottom line and the reason why I think there's been an increase in relapse and fear of relapse is simply because either those support systems weren't strongly in place, or because someone is not self-advocating and maybe looking for a loophole.
Paul, can I add to that?
Yes.
Those in progressed active addiction are well described by Marilyn. But what we're also seeing is that people who are in the category of misuse, and there are about 40 million people in this country who are in that state of substance use disorder, this quarantine, this crisis, this fear of and uncertainty is going to accelerate that process. So not only do we see people who have already been diagnosed, maybe are in treatment with support systems, but people who may have stayed in that misuse category are being driven by all of these circumstances to progress faster into the disease. And, to drive the situation home a little bit more is that, the opiate epidemic has been called the worst drug epidemic in modern history. And now you've got that compounded, to use the word probably too lightly, by a pandemic that the likes has never been seen. And so if you talk about, the worst drug epidemic, or as Judith Grisel wrote in her book last year, that worldwide addiction may be the most formidable health problem. Now we've got a pandemic that's the most formidable health problem. So, what we're seeing on the front lines here is very significant in terms of substance use disorder, depression, anxiety, and mental health.
Thank you for sharing that. Yeah, I want to say something, and from here on out, feel free to just jump in whenever. So one of the things I was thinking about when I was thinking about recovery, and I worked a lot in the substance use field for about 5 years, and I became a trainer for doing an adolescent outpatient program, which was more based on incentives and rewards and getting into new patterns. So these were people that were not in the addiction category yet. They were probably in the misuse category, just kind of young and identifying. So what we did is we tried to help them have a more rewarding life away from using. So a big part of the program was working on the family relationships, helping them get into sports or something. Interestingly enough, in Phoenix, some of the kids got into this really cool some sort of radio program that helped kids learn internship. That's it. Different little activities, and improving all those areas of their life. There just was less reason to use. There was less reason to go to the park after school and smoke or drink or whatever, because they were more satisfied in their life. And because the addiction had not taken hold yet, they were young. They weren't, and the ones who had taken hold, they needed to go inpatient or into intensive outpatient. But we were on the low end, right? These kids had just been identified. So one of the things that really helped was getting them into these, what I call like healthy habits. So not only did the relationships improve with maybe their siblings or their caregivers, but they would start getting into choir or sports or a friend group that did a book club and all these things. So they would have this consistent pattern several days a week of things to do after school and before school. And lo and behold, not all of them quit 100%, but their rate of use was usually going down to once a week or less, right? Or maybe twice. There wasn't this 5 day, 6 day a week use pattern anymore. And what I'm finding with the pandemic is that people are finding it very difficult to have any sort of consistent healthy habit, because the gyms here in Michigan are still shut down. Although some states have opened them with masks, like Colorado and Arizona, we're shut down. So the gym is out, right? So you kind of have to be exercising outside. And sports programs for kids are pretty much shut down from what I've read. The school day is now weirdly differentiated, but depending on what sort of school you go to and where you go, and it could be online or it could be partly online or it could be partly in person or something. That's not we're not in a new pattern yet. And then for your adults, I'm hearing a lot of this. Well, I wake up and it's the same day every day. I don't have the recreational opportunities to go see, my elderly family members. I'm afraid to infect them with COVID-19. The concerts aren't happening. I don't want to have a big get together with my group that I'm a part of because it's too dangerous. So we were on Zoom, which is fine, but not as, it takes a lot more effort. Things are all taking more time. Do we meet out? Do we not meet out? Do we social distance in the park? Who's safe? Who's not safe? So all these little mini stressors on all age groups I think are compounding into, we don't have any consistency right now besides people that have a job, which you need to go to. There's not, the patterns of our life have been disrupted. So therefore, when you're trying to make a new pattern, and some of the research says 180 days is when it starts to stick, a positive pattern, we aren't really getting to that for people that are in recovery. So then if you're every day having to deal with a different stressor every week, there's so many triggers and stressors. We have the classic hungry, angry, lonely, tired, halt, those are signals to use. Or we're finding couples if they have children or not. If they have children, way worse, because they're arguing about where should the child go? Should the child be at this birthday party? Should it be an outdoor party? Should it be a Zoom party? And then couples, the increased demand for couples therapy in the last 3 months from my office is going through the roof. People are, breaking up and doing other acting out behaviors. And then all of this is bathed in increased substance use, which then gets us into even more trouble, right? People are acting out in more bizarre ways. And as you know, a lot of accidents and suicides, there is some substance use involved. So I kind of was just talking about the triggers, the relapse triggers, and the negatives before we move into anything positive. Kind of wanted to get all your takes on the triggers that people out there, if they have family members or they themselves are struggling, what are these things that are, what are the negatives that are causing it? And then what is it? Maybe we'll get into what are some solutions.
Sure. One, I think this is a good clinical question that Linnell can more thoroughly address. But one thing that you pointed out was about exercise, and exercise is a huge component in the area of recovery. And I'm not talking running a marathon. I'm just talking getting your body moving so those chemicals start flowing again. And we're here in Michigan, and so right now we've got some pretty nice weather that we can go outside and take a walk. That's going to come to an end as well. And so as a facility that treats people where we do exactly what you said, try to get them moving and new routines and new patterns, with exercise being a big part of that, that's going to be dramatically impacted under our already confined parameters by the onset of winter. So I'll let Linnell speak a little bit to our previous program of excursions and how we would take the clients out into the community to develop the skills that you described, and how we're handling that in the residential area right now.
Yeah, just what we're talking about, doesn't it just show you the importance of recovery and how we need to be providing that support for them? But yeah, that has certainly been a challenge as the clients come in. That is one thing that we talk about, because even in some of their addiction, some of them still had some healthy outlets. They still were able to exercise. There were still things that they were doing, and all of a sudden, some of these things are going away. And we're finding that a lot of them don't have healthy coping skills. And so when these voids begin to develop, they don't know what to do with it. So that's something we talk about as far as how do we go forward? What do we do in these times of uncertainty, but that we still want to have healthy recovery, and that there are options. So let's dialogue about that. Because even for us now in the houses, we used to have weekly excursions where we would take the community out into the community to have opportunities to explore and see new adventures and discover things that they can do in recovery. And with the COVID-19 and the pandemic, we're not doing that anymore. And so we're trying to find other ways, other healthy outlets for the clients. So that's an ongoing challenge. But we're able to go for walks. We're able to go to a park. We're able to do some activities outside and try to encourage, let's implement some of these things. It might be different, but it might be also a good change. And so that's a constant thing that we're talking about.
This is Marilyn, Paul, and I think you hit the nail on the head with the concept of structure in recovery, and also identifying as something outside of yourself. And just from a personal standpoint, I think this is where discipline kicks in. especially in a situation like COVID-19. We in Michigan, we had a snowstorm in April. I identify as a nature buff and a hiker. And on top of everything, as a kayaker, and on top of everything else, pandemic, and then snow in April. So, whenever I'm feeling that Sunday afternoon feeling, and a little concerned about potential for triggers, I just put on some hiking boots and go. And I did that like throughout this whole thing. I was able to find Blandford Nature Center gets my gold star for helping me during this whole process, because I would just go there. It was quiet and put a mask in my pocket and go for a walk. I always felt better about after that.
Paul, you also touched on couples therapy, and during this quarantine, there's been a pretty significant uptick in domestic violence, of course, leading to substance use disorder increases as well. So you're spot on with that. We're seeing the reasons that people are coming into treatment and the struggles behind their reasons for coming in much greater because of this quarantine. One other thing I'd like to add that your interview actually prompted me to start thinking about and reading some articles on is that not only do you have those that are seeking help for substance use disorders, for all of the usual reasons that they may be predisposed to a substance use disorder, but we've got a ripple effect going on here. We've got, family caregivers who are taking care of aging parents, that are unpaid caregivers committing their time to that. And this pandemic is taking the toll because the respite services for these people have been impacted. Isolation is compounded. We're seeing a surge in responses for opioid overdoses, up 26%. And the ripple effect of that is first responders. So those first responders are also seeing more traumatic day-to-day experiences. And so we've got a layering here of those being impacted by the substance use disorder propensities, if you will, through the quarantine and the COVID crisis.
So, yeah, I want to let anyone jump in when they want to, but here's what that prompted me, because we are at my office, also known as the Trauma Informed Counseling Center of Grand Rapids, and we focus on treating people in outpatient after they've kind of been through a trauma, or they're maybe in the middle of a chronic toxic stress situation. And so we have treated first responders, and one of the biggest difficulties is if they come across an overdose or a suicide. It can be devastating to the fire department, the EMS, the police, that they have to go there, and that can really affect their stress levels, right? Not only that, but then we have the news reports, and this is, it's real life. This is reality, what's happening. But then we're having negative news reports constantly, and people seem to be tuning in more to that, gravitating more to that, which then leads to more stress, more mental duress, which can then lead to more substance use, which then leads to the exact same problem. We're kind of in this circular thing. And so it really is difficult if you have any predisposition to a substance use issue, or you've been in recovery at this point. It's just another challenge to have to get more self-care, get more, how do you get community? How do you become more intentional? How do you help yourself? And when I say this, how, usually the people that are educated or, have been through a recovery program can kind of know, but how about all of these people that are in the misuse category, right? And they're just dabbling. They're going, oh, there's a new type of seltzer by a certain giant brewer in the United States. I'm going to try that out, right?
And I can try it at 4:00 instead of 5:00,
right? And I'm
at home.
And I've heard this too. Yeah, I'm working from home. Why don't I have a drink? Go ahead.
And anxiety and alcohol go hand in hand.
Mm-hmm.
I mean, there is a half glass of wine is in fact a bit of a stress reliever. So you start with that, and then it compounds.
And then our bodies get into that and get used to that, and thus the tolerance increases, and the need for more alcohol or drugs increase, and thus then our brain gets wired into addiction. And so I know one thing that Sanford House has been doing really well, that I very much enjoyed our working together in the community, is that you are working to break away this stigma and shame about addiction and what is addiction, right? Because we're talking all about these behaviors right now, because I think people can relate to that. And I've got plenty of podcasts about what is addiction, but addiction is a condition in the brain and in the nervous system and in the biological systems that persists, right? And then, and this is my perspective in the trauma world, I believe that is kind of the beginning. And then people make up stories and narratives about it. And in our culture, we've had a lot of negative narratives towards anyone who had any sort of misuse or addiction. And then if we say negative things or shame them, that causes those people usually to withdraw further and use more. So how is Sanford House, and how can the listeners? So first, how is Sanford House, and then how are the listeners? How can we help people that may be falling into the misuse or even the addiction category when there's all this negative societal shame and blame put on people that use?
Well, you're hitting on our philosophy at Sanford House is, first of all, to care for those struggling with this disease. And as you said, it's a brain disease. Thankfully, the Surgeon General in 2016 came out with a lengthy report on the disease basis for addiction. So the shame and stigma that accompanies our clients as they come through the door is overwhelming. And part of our mission, not part of a big reason that we exist and the way we designed our programs, is to help educate the culture around those with addiction, the society and its perceptions of addiction, to understand that this is in fact a brain disease. It's a disease of an organ of our body, much like diabetes, and diabetes takes, lifelong management, and that's how we need to approach substance use disorder, is lifelong management of it. But we set the stage with our real estate and the houses and the home-like welcoming environment, so that when people come in, they can feel validated, and we can immediately start chiseling away at the shame and the stigma and the understanding of the neurobiology behind what's happening with them. Because their families are generally mad. There's debris in their wake as they come to seek treatment at usually a crisis point with some external motivations, a DUI, a husband threatening to leave. So the circumstances that people come in with are not like you'd see in a cancer ward where someone is being welcomed and can I come and visit and can I bring you dinner? There's a lot of anger and stigma involved with, why did you do this? Why don't you love me as much as you love the bottle? So the Sanford House setting is one that we immediately begin to validate the work that someone is doing as courageous and necessary. And with that, maybe I can hand it over to Linnell to talk a little bit about the clinical aspects of that.
Yeah, I was thinking about a couple of things to kind of dovetail off of what Ray was saying. First of all, kind of changing that narrative of that typical shame-based self-criticism, right? The stigma that's out there, they hear it from the community, they hear it from their families. And so a lot of them come in with that mindset of that shame-based criticism. And so it's exciting to be able to sit down and begin to work through that, to take them from that narrative to more of a self-compassion, self-correction. And not look at it as the criticism, but look at it as, how can I take this forward and look at it with compassion and work on the things that I need to do. And one of the things when Ray was saying that is something also that we offer for families, because a lot of families are at the point where many come in and they're ready to file papers for divorce, or they're ready to take the children from them, or they're ready to just be totally done with their child or whomever. And so we see that a lot. And so for us to be able to have those dialogues with families and say, are you willing to join a support group? Are you willing to come into an educational evening once a week and begin to educate on this disease and help to understand what's going on? And we find when we're able to bring the family together and educate them a little bit, that it really has helped for the families to come together and begin to look at this as a brain disorder, and not just because their loved one wants to go out and wreck their life, or they want to, be destructive in things, and that they don't care. So self-compassion, Paul, is a big part of what we do. And it's more than just being compassionate to yourself. It really is beginning the process of building resiliency and bringing in that common humanity, that we're all going to struggle, we're all going to have to work through things. But as we show self-compassion, we can build that level of resiliency to be able to deal with some of the stressors, especially nowadays with some of the ongoing uncertainties that we're facing.
I love it. Who else wants to chime in on this?
Well, the one thing I would say too is that we haven't really talked about it yet, but the behavioral health field has really turned on a dime in the last few months to provide as much as possible virtual, telehealth and treatment in virtual platforms. And one of the things that Sanford has done during this period is to really reach out to our alumni and to the families, as Linnell was talking about, and to provide for them telehealth or virtual related programming, so that during this period of time, instead of anger or some other negative emotion, they're more understanding and empathetic, and learning some tools right along with their loved one in recovery.
I went to a lecture, Paul, and I wish this were my line, but it was someone else's that I frequently borrow. And it's that this is the only disease that heals with love. And so when you're healing from this disease and you need a community around you and you need the love to begin that journey of recovery and the healing process, I think we've pivoted to a telehealth platform and uniquely been able to provide some of that community in ways that we had to get really creative to do it. And it takes a skilled counselor in the area of substance use disorder. It really takes a skilled counselor to make virtual therapy successful, to reach in with depth and richness and read behind the scenes, because with addiction, the symptoms of the disease are behavior. And so for our therapists to be able to chip away at the defense systems that are a part of the disease are a little more challenging in virtual telehealth. But we've been able to pivot and provide those services to our clients and to incoming clients that are just beginning the journey of recovery. But you'll never replace the community and the peer supports of being in a residential treatment center or an outpatient in-person setting. So we are not blind to those challenges that lie ahead as COVID-19 doesn't appear to be going anywhere soon. But we've been able to, in a therapeutic way, implement this invaluable tool. And then going beyond the quarantine and the reasons for it are that we're now in a position where we can service people when they leave our residential community and go back to their homes in Alpena or someplace that doesn't have services available, to be able to properly support them in a really critical way through virtual telehealth. And with that, maybe Linnell can speak a little bit more to what she sees. I know one thing that we see in telehealth is a lot more pets in treatment, because people have their puppies or their kittens sitting on their laps, and so there's a new level of intimacy when it comes to telehealth, which is actually, I think, beneficial in helping clients and therapists develop a therapeutic relationship in a deeper, richer way.
I think we found with telehealth that there are some advantages to it. And it is meeting the needs of many people that maybe still are ambivalent about their addiction, and they're not ready to come into an outpatient facility, or they're certainly not ready to come into a residential facility. And the great thing about it is it begins to open up those doors of maybe this is something I need to do. And so we have seen that a lot with clients that will call and say, I'm going to give it a try. Can I come into your IOP program? Can I start there first? And then as they begin to meet in the groups and develop relationships and start not feeling so isolated, we will have clients say, I look forward to every time we get together, even with the being telehealth, to be able to see people's faces. And even through the screen, we're making connections, and that is vital. But the thing I like about it, there's many things I like about it, but one thing that I'm seeing is that we do have clients that start and have that ambivalence, but soon after getting involved and connecting with other people, realizing they need to go to a higher level of care. And then we're able to help orchestrate that for them and bring them into residential. And then they can begin that journey even in person. But, it is exciting to see that even through telehealth, that we've been able to reach out and help people. And I do want to say another thing about telehealth, that we've been able to connect with families that are in different states that we hadn't been able to prior. And our support group is, once your loved one has been in our program, you are alumni as well, and you can stay within that support system for as long as you want, and you can stay within the educational piece as long as you want. And so those are things that have been exciting, that we can reach a little further than just Michigan or even, a few states around, is that we're actually going on the other side of the United States. And that's exciting.
So that is amazing. Go ahead, Marilyn.
To me, it's super exciting too, because, there's so, I love to hear our clinical director wax poetic about telehealth, because it's here to stay, one way or the other. Walmart, Sam's Club, CVS are all establishing telehealth programs, some actually with behavioral health capabilities. So when the big guys are jumping into it, we know that it's probably going to stick around. But for us to be able to meld it into our continuum of care is pretty exciting.
Yes, I want to know in a moment about all of the things the Sanford House has to offer, Sanford Houses and the addiction treatment centers that you have, because I want the public to know about your program, because I find it very unique, honestly. I had a few comments. First of all, on the telehealth bit, I have found there's a lot of pros and cons. There's always trade-offs, but having telehealth now validated by insurance companies, most of them, and having that as an option is actually very good as a hybrid, especially when this pandemic kind of comes to an end. Having this as an option, because like you said, you can reach families, you can bring in people from other states. For instance, in family therapy, I even had a session recently where two of the members came in with masks and, in our socially distanced office. And then the other member was on the computer, and we had a family therapy session, and it was fantastic to be able to utilize that tool. And then, as you said, we'll get into, your continuum of care there at Sanford Treatment Centers, but having that alumni group and that support group. I know that a lot of substance use support groups, just the basic ones that are, like AA and NA and all of that, are going online. A lot of the parent support groups are going online. And I know that your support group has gone online due to COVID. You can't be bringing in 20 different people from whoever comes that week until this is over. So I'm seeing it as a positive. I miss some of the in-person, but I think at this point, more connection in whatever way we can do it is always better. And so I think eventually it will be a hybrid situation. And I just wanted to throw out there for the listeners, and I'm sure you already know this, but Kristen Neff from the University of Texas at Austin's Department of Educational Psychology has been studying self-compassion here for about, I don't know, 10, 15 years. I saw her speak in California last year. And she is now proving with clinical long-term studies that doing a 5-minute or more, usually more, self-compassion practice can improve all sorts of conditions such as depression and anxiety. And as we know, depression and anxieties are huge comorbid, co-occurring factors when it comes to substance use. So the fact that Sanford House and addiction treatment centers have taken self-compassion as one of their central missions to help with the clients coming in, I think is not only a great idea, but now is empirically proven as a valid intervention to behavioral health. So I wanted to compliment you on that. And I will say, sometimes the substance use continuum of care in the greater gestalt of the United States gets a bad rap. For listeners out there that have kind of said, I hear, let's pick on Florida because Florida's annoying to me right now. Come to Florida. We've got these great treatment centers and it only costs $60,000 and possibly, sign over your life insurance policy to us. And then your kid will be great. They'll be fixed and, good luck. Right. And I know that's not everyone in Florida. So no libel suits. There's plenty of good treatment centers in Florida, but there's that sort of idea that sometimes these treatment centers are not working with the family. They're just, trying to find people who are desperate, to come in. And I know Sanford House is the exact opposite of that, which is why I put your literature and everything out at my office. But I want to talk about, why you guys are different than other treatment facilities and how you have worked on the mission statement and how you work with families on cost. And I've already heard stories in the community of you working with families on cost, helping them out, trying to figure out the best thing for them. And also just the fact that you have these free groups that people can attend far after they've graduated from your treatment program, which I think is, I don't know, I haven't heard of that before, honestly, except, with SMART and AA. So if you could elaborate kind of on your continuum of care and why you guys are different. And, especially here in Michigan, there's not as many options.
So Paul, I'd like to have Linnell talk about our continuum of care. But before we start that conversation, I wanted to circle back around to something that relates to this pandemic and telehealth, is that when the news reporters started picking up on the opiate crisis, it started a dialogue that made the conversation about substance use disorder more comfortable for this society and culture as a whole. And that was resulting in some progress. But this COVID-19 and the resulting telehealth has done a similar thing with people's comfort level on seeking treatment. A younger generation that grew up with computers and with that being their comfort level are now approaching substance use disorder through that platform. And older people, I won't mention my own name or any other names, that maybe weren't as comfortable with these platforms are gaining a comfort level with it. So it's expanding our ability to connect with others in a way that may not have happened otherwise. Just as the opiate crisis created a dialogue where people were more comfortable talking about this disease, it was due to unfortunate a price that we paid both in the COVID and with the drug epidemic. But anyway, with that said, I'd like to talk about the continuum of care. And the exciting news for Sanford is that in 2021, we will be opening up a subacute detox. And what that means is that we will be able to medically stabilize clients that come to us. Right now, we use other detox facilities to do that, and there is a dearth of beds. There are not enough beds in West Michigan to even begin as a drop in the bucket serving those who need detox. So that's going to be part of our expansion in the next 6 months, which will take us into 2021. And with that, I'll let Linnell describe a little bit more, starting with our continuum of care and residential. And remember, as we have this discussion, people don't go through this continuum of care in any particular order. People can enter at different levels of care and move up or down through the process. So with that, I'll let Linnell talk a little bit about our continuum of care.
Sure. If I talk about the levels of care, if I start at our highest, which is residential, that's anywhere between 2 weeks, 30 days that the client would come into either the Cherry Street facility, which is gender specific female, or John Street, which is our male. And so they would enter that and stay there. Some stay up 2 weeks. We like them to stay longer, up to a month, and some have stayed a little bit longer. But the continuum of care then is, for some, they'll go into partial, which is our day program, and then they can transition into our intensive outpatient, which is an additional 6 weeks. And then they can go into our outpatient program, which really can go into up to a year, especially if the client participates in our medication-assisted treatment program. Even through telehealth, we've been able to continue all of those tracks. Our medical teams are able to talk to clients via our telehealth virtual meetings, talk about their medication. Some will still come in to get their Vivitrol shots, but a lot of that is also able at this present time to be done through telehealth. So it's a good continuum. That's one of the things that I really like about working at Sanford. As we know, working in this field, the longer that they're able to stay with the consistency of treatment, the structure of a program, just the better chance of them staying in long-term recovery and learning what that's going to be like.
Wonderful. So yes, and that's a very important aspect of treatment, I think, especially what I was talking about, this sort of like cure-all treatment center idea, is that there's sort of a fantasy in our culture about this, like, quick fix, a pill for an ill, they say, or, oh, I'm going to go to treatment center, and then after that, I'm going to be good. I'm going to be drug-free forever. And so the real work is there, in the inpatient center, but then it's also in the partial work, because you've got to be partially in the community, and you've got to learn how to implement this with the triggers that could be literally your kitchen. Your kitchen could be a trigger. Opening the refrigerator could be a trigger. Anything. If you have and what I mean by trigger is something that's influencing you to use in a kind of an impulsive manner. And the way I'm using it today, although there's many other versions of that, I'm referring to the substance use trigger. Sure. And then when you're when you graduate from that program, then having the intensive outpatient experience, which is a group therapy where people get to learn new things, try new techniques, but also share their story and learn how other people are coping, and that can be done right now over telehealth, as I know you've been utilizing that. It's then that the challenges really start to appear. If you're only going a couple days a week to therapy, and then you drop down to 1 day a week of therapy, and the rest of your life is a challenge, and that's how we implement these long-term changes. So the fact that it's all under one roof or treatment center, it's not one roof, multiple roofs, but the same program coordinating it is so important and vital in my mind, because a lot of treatment programs, they're like, oh yeah, for aftercare, go to a therapist, or there's like a little bit of aftercare, but the aftercare is where the work that you've done detoxing and learning these things begins, even again, until it becomes a lifestyle. The lifestyle is a lifestyle of recovery, and not just recovery, but loving your life and finding outlets and finding different relationships. Another big one, finding new relationships, because after somebody's done using or reduces their using, depending on their situation, a lot of the people they used to associate with may not want to hang out with them if they aren't going to participate in the use
That's absolutely
behavior.
true.
So Ray, so tell us, what are your thoughts?
So if you read any of the government websites, you're going to see that some of the statistics indicate that 50% of relapses happen within the first 90 days. And so the critical treatment portion of keeping someone's brain cocooned in a healing process during that first 3 months. And that's a primary motivation for a continuum of care, is to keep someone in that process while their brain is still very vulnerable to post-acute withdrawal and the relapse recurrence process. And then what we view our job is in that continuum of care is to prepare people for that lifelong journey. And when we say lifelong disease management, we include that change in lifestyle, and our role is to help them achieve that. And so some of those courses in outpatient, we like to call them courses because we look at some of our programming as when you go to school and that exciting first day when you're picking an elective and you want to take certain classes, we try to provide options when we get to the point of those outpatient courses, such as relapse prevention, or how to live a life of wellness and recovery, or holistic aspects to recovery, so that we make it interesting and exciting as people go on through that continuum of care and into the long-term journey of recovery.
Well,
sorry, Mary.
Just a quick aside, those same government websites that Ray was talking about also show the statistic that a year, a solid year of some sort of formal treatment will reduce your relapse rates to about 20%.
Right.
So the longer the better that you can be, connected to some sort of formal treatment.
I just wanted to say, in addition to what Ray was saying about post-acute withdrawal, we have clients that come into residential, and a big part of what we do in the time that they're in the residential is really stabilize them, work on just their medical, their mental, their spiritual, their physical. There's a lot of different elements, that holistic picture of looking at each client. And so with the continuum of care, it gives, like Ray said, the opportunity for the brain to heal and for them to be able to look at life. Because when they're in residential, they are protected. It is a little bit of a haven, They're still talking with families, but they're not dealing with some of those stressors that they would if they were out living in the community again, or triggers of being home where maybe that's where they drank. So the continuum of care then provides the opportunity for them to be in groups and individual sessions on an ongoing, consistent basis to recognize the humanity, the common humanity of the struggles that we're going to have. Just because you're not using your drug of choice doesn't mean everything is going to go well. And so that continuity of care and that continuum of care helps to equip them to learn to be able to deal with those stressors, because they're not going to go away. In fact, sometimes they're a little bit greater because we're not numbing now with that drug of choice. And so that's another reason why I believe the continuum and the continuity of ongoing care is just vital, as Ray said, in those especially first 90 days where it's very common for relapse to occur.
Very good. I feel like I'm getting a good picture of your program, and I know you have 2 different houses that are beautiful, old, gorgeous houses, historically restored here in Grand Rapids, Michigan, and those are your inpatient, right? And then I know you also have some sort of treatment facility nearby where you were doing outpatient therapy and intensive outpatient therapy, which I'm assuming now is they're still using it, but it's more of a telehealth, more of a hybrid situation. So what about, I want to know about a couple of things about your house, the treatment center, but also I want to kind of put some questions out there for people that, may be looking for a resource. So the first thing is, Can you just tell us a little bit about how you normally handle somebody coming in and calling and saying, hey, I need help, and then maybe a little bit of how you've been handling it since COVID quarantine has began?
Sure. So we have a very compassionate, skilled admissions team. One of the admissions specialists is a nurse, so that we can do some medical screenings when necessary, which is a lot of the time. And the first call is, to Sanford House admissions or an inquiry on the website, which we try to respond to within a day. And that's generally what happens is we begin a screening and assessment as to what level of care someone might be in need of or what they're looking for. And it's oftentimes the hardest thing is just picking up the phone and making that first call. So having someone reach a friendly, welcoming, compassionate voice at the other end of the line is a big part of our job. If Sanford House, for whatever reason, is not the fit, and that can be for funding reasons, geographical reasons, there's a myriad of reasons that it may not be the place, we also serve as a resource bank. So we give people phone numbers to call and help them get to the places that they need to be. But if someone comes into our treatment, the first thing we start out is a biopsychosocial, and that comprehensive assessment helps us determine, where they should be at and what level of treatment they should be at. So maybe I'll let Linnell speak a little bit more to this, but it really is a phone call or getting on our website and looking at what the options are, Paul, to see what's there. The two houses are because our philosophy is gender specific. We really feel, and the research supports, that men and women heal better in a gender specific environment. That's true at the residential level, not necessarily at the outpatient level, because as you said before, that's when people need to start stepping back into, the real world, so to speak. And Linnell, do you have anything to add to that?
Just recently, I'm noticing it more, is the families that are calling because of the stress of COVID-19 it's already over the waterfall. There's such desperation on their voices. You can hear as you speak with them about getting a family member into a treatment facility, and I don't have any other choices. What am I going to do? And our admissions team does an excellent job at coming alongside and personalizing it. And we look at clients as not just a number. They're individuals that we want to care for, and they have a name, and they have a life, and they have families. And so we really try to, from the very beginning, from that very first phone call, make them feel as if they are special and that they are important and that we want to be able to help them. But the process is, once they're approved medically and clinically to come in, then they would go to the houses if it would be residential. And they would right away meet with a therapist that would be assigned to them. And we do the biopsychosocial. And it helps us to understand what are some things that we can work on. What's your treatment plan going to look like? Person-centered. Each individual has an individual treatment plan. And what are those things we're going to do while you're here? How can we prioritize some present concerns? And then we'll continue that. From the very beginning, we're already talking about aftercare because we know the importance of that, providing that stability.
Paul, one thing to note is that when we founded Sanford House, we founded it for an underserved population. And it might be surprising to hear that underserved population are those who have private insurance. So only 20% of the people in Michigan with private insurance seek treatment, and most of them were going out of state. And what my husband and I saw when we were doing our homework on founding a treatment center that was different and unique in the state of Michigan was that people were in fact leaving the state to get treatment. Now, a lot of that is rooted in insurance coverage and reimbursements, and Michigan is not known for its reimbursements for mental health. and substance use disorder. So anyway, I think it's worth noting that one of the underserved populations here that we were reaching out to, and we're expanding that reach and looking at public payer sources now and different options on how we can help people who are in desperate need of help. But to start, it was that privately insured population.
Yes, and that gives people an option in the Midwest to stay a little closer to home. And as literature would indicate, California, Arizona, Colorado, and a few places in Texas and a bunch of places in Florida are kind of the as far as I'm understand, the prominent treatment centers. So people are flying out of state, they're away from home. Here it gives them, some of that familiarity if they're from here in this area. So, and we're only about 2 hours and 10 minutes the way I drive to Chicago. And so that's good. And we're about, I don't know, what will be an hour, 45 minutes from Detroit, or it depends.
But about that, that's right. And that's
suburbs
pretty
are closer, but yeah.
For even families to come and do family visits and that. And we're a comfortable, welcoming setting in historic homes, but we like to pride ourselves on Midwestern values. This is a program where you work hard. And it takes a lot of courage to come in and we provide the space that feels welcoming, but it's hard work. It's not a luxury spa-like program as some of them on the West Coast advertise themselves to be. It is something where you come in and do what it takes to begin the healing process from a very devastating disease.
And a very community oriented. I'm really looking forward to the pandemic being over, so you guys can get back to a lot more of the community stuff that you've been having to hybrid. But I noticed that, and we do have an international airport here, so people can fly in for it. But some of the West Coast, I feel, and Florida, over marketing and the pricing of those were based on the fact that they had these sort of amenities that seemed luxurious, right? And I see it seemed like the focus was on that versus the focus was on the treatment in the community. Seemed to be lacking at a few, especially even in Arizona. I'll pick on Arizona. There was some in Prescott, Arizona, that were lacking some of this community. They were focusing on, we go rock climbing here and there and all that. And it was like kind of their marketing scheme. So I think we're missing if we're talking about the food and the amenities as the main draw to a treatment center, I think that's the wrong focus. And so I like the fact that we are using what are the latest empirically proven therapy techniques and mix that with the number one thing we know that works in every type of therapy, which has been proven statistically in multiple books by Bruce Wampold and other researchers, which is the relationship between the therapists and the medical professionals. You can look this up in Bedside Manner. You can look this up in any sort of research. For doctors, it's the same thing. Compliance with treatment plans, it goes up if the doctor and if the client believes the doctor believes in them and they have a good rapport. The treatment basically gets better if the therapists have that person-centered approach. And so Sanford House, as a treatment center, has a person-centered approach that is non-judgmental, non-shaming, non-blaming. We're kind of we're getting out of that. We're completely countercultural to the old way of treating substance use, which was confrontation, shaming, telling people that they were terrible, all these stupid things that are completely based on people's emotional reactions to their anger about the substance use and the behavior, which can be, is a valid emotion, but it's not a successful way to treat the illness. And obviously with person-centered and love and care and hard work, we also have the boundaries and a ways to set loving boundaries so that people have less incentive to use upon returning.
That's right.
And more incentive to live a life in a healthy way. So that's kind of how I see.
When we talk about the relationship, the relationship between the therapist and the client is in fact evidence-based. That's an evidence-based treatment model. And when you're coming into treatment, it's really important to have that therapeutic engagement as immediately as possible, because we only have a little bit of time. I mean, a month may seem like a long time, but when you're treating substance use disorder, that still feels like we've got to get everything done that we can in that amount of time. And so our clinicians are particularly skilled at creating that compassionate, welcoming, immediate therapeutic engagement so that we can hit the ground running.
And for some, that is the first time they've ever had any interaction with someone that really cares about them and actually is not judging them. And for many, they come from families where they've been criticized nonstop. And so for them to be able to come in and build a rapport and actually feel special and needed, I hear that all the time in the houses with our men and women, that there's so much shame, there's so much self-criticism that they put on themselves, kind of that inner critic, that we all tend to have sometimes. But a lot of times in addiction, it is very, very strong. And so I have found personally, being a therapist and working with the therapists at Sanford, the importance of that building relationships and the importance of developing that rapport. And that is a big part of recovery.
I love it. And there's a quote, I don't know who said this, but they said, if punishment worked, there would be few, if any, people with addictions in this country. So punishment doesn't work. Boundaries work, limits work, compassion works. But we really, if you're in this is for the audience, if you're in a situation where you feel like your substance use is starting to get out of control, it's impacting you socially, it's impacting your relationships, it's impacting your work, it's impacting your sleep, your health, there is help out there. And I know that you all answer the phones and the emails, and there's a thing called triage, which means that if we can't help you, we'll find a place that can help you. And I know I do that all the time. Every week I'm answering phone calls or emails from people that I can't even serve here at my outpatient clinic. The good news is that now, due to telehealth, not only is can they serve you in the homes, but if you're, depending on where you are, I'm assuming we can now serve people long distance as well, depending on the qualifiers. So is there any advice you have out there for two sets of parties? Party number one, people themselves who are feeling that they're starting to have an issue and they're afraid that they're going to go down the wrong path of addiction, which can lead to terrible health outcomes and awful life situations. And number two, the family members of anyone who they believe has an addiction they're worried about. Is there any advice you can give to those two groups? I'd love to give you all a say.
Pick up the phone. Mm-hmm. Pick up the phone and call somebody who can help educate you on the process. And the reason it's important to pick up the phone and not wait is because if you think something's going on, it probably is going on. And if you're sensing symptoms or signs, or you're questioning yourself or someone in your family, the likelihood of an issue is pretty certain. But the other reason it's important to pick up the phone is because someone can start sensing these things at the point of misuse. And if we can start capturing people at the point of misuse before it's a fully progressed chronic disease state, then there's still some choice involved there. There's still options to learn about the disease and have some lifestyle changes and that. So I think wherever you're at, don't wait until it gets to be a crisis. Pick up the phone and get your information and do your homework.
I would say the same thing to begin with, just dialoguing. Not everybody that comes into treatment even thinks they have a problem. They know there's some issues there. One of the reasons why we use the motivational interviewing is the opportunity of being able to dialogue about, maybe this is an issue. Let's talk about that. So even just picking up the phone and starting that dialogue can be so important. And just one point for families, there's a lot of families out there that are just desperate to get help for their loved one, but their loved one might not be ready to get that help. And so my advice and suggestion is that the family member get the help that they need, to set boundaries and good self-care for themselves, because we know how that is when people are caring for other people. There are so many times they're not taken care of. And so that would be something else I would encourage families. If your loved one isn't ready, then take care of yourself and set yourself up so that you can be in a healthier place.
And one last thing from me, and that is just asking for help. You know, we've been talking about isolation. I think the disease of addiction is a lonely thing. And so many people who are struggling think they're the only person who's ever experienced what they're experiencing. So asking for help and starting this dialogue, I think it's a real relief to know that you're not alone. You're not the only person who's ever done these horrible things.
I like it. And, just for people out there, a symptom of depression, which is always exacerbated by substance use, is sort of this, often can be accompanied when you're feeling terrible and depressed, that you are the only one suffering. And that's actually a symptom that we see. I don't remember what that one's called, but it's in the DSM, where it's like this sort of myopic focus on the problem and myself. I'm the problem, right? And it's not true. Everyone has a problem, and we're all on a spectrum of anxiety and depression. And right now, due to toxic chronic stress of the worldwide situation, which you may be in, or just moderate stress, your continuum of anxiety or depression may be pushed one way or the other. And if you've got any substance history in your family, or you have yourself had a period of overconsumption or misuse, your spectrum will be pushing towards that addiction state that we don't want to get into, because that's when it gets out of control. And that's when you start to, like, I think Ray said there, or somebody said, there's still some choice involved. That's when you start losing your freedom and your choice and your control. And I think one of the biggest things with being a human is we hate losing control. We want to control our bodies and our minds. And the hard part about substance is, while it deludes you into thinking you're in control, you actually start to lose control over time. And that is a biological fact. It's not anything to do with your level of tenacity or resiliency. It literally is just biology that it will overtake you, just like diabetes, just like heart disease, just like any sort of skeletal muscular issue, any chronic autoimmune disorder. It will take over. And then what happens is you lose control of your life. So before it gets there, and before your family member gets there, reach out, get help. We'll have links in the show notes how you can get a hold of Sanford treatment centers and all of that. And I'll probably throw some general links in there as well for some of the free support groups, just to get your toe in the water if you're thinking about it. I'm so grateful for these amazing people that have been on my show today. I want to give you all a chance to say like a kind of a parting word or something to the audience, or whatever you want, if you'd like, before we close out. So who wants to go?
I'll start. This is Ray. There's hope. Don't be discouraged. It's a disease that takes its toll not only on the person struggling themselves, but on their families. And there is help, and life can be better than you ever imagined when you find the bright place of recovery.
And I think just to say again that you're not alone, the common humanity that many are struggling with addiction and other issues, and to just reach out. There are people that want to come alongside and help and encourage in this time.
And I would just say that there's a myriad of opportunities via telehealth and virtual platforms, and they are everywhere. You just Google them, and there's really no excuse to be alone and isolated during this time.
I love it. I could not agree more. And, I've worked as a therapist for over 13 years. And what I've seen time and time again is people, whether they were clients or family members of clients, and they say, well, no one could ever help them, or nothing could ever change. And that's also a symptom of depression. So it's an untrue thought that our brain thinks when it does not know of a possibility. So seeking outside input. You need input from the outside, and education. They say knowledge is power, but education is the key. And just learning a little bit about this breaks us out of our cultural and family narratives that may be perpetuating our negative self-image or reasons to drink, reasons to use, and also our secret reasons to use and secret reasons to drink that we may not want to tell anybody about, which may be trauma-based or spiritually based or physical situations. And so all of that can be taken care of in therapy. That's why there's a custom approach at your place and at my place, where we do not put people into boxes. The substance use is a symptom, and it's a symptom of something greater, which is people are lacking meaning, they're having difficulties, and there's always 5 to 20 dimensions of why the problems occur. So by acknowledging and accepting that you may have a troubling issue, it's a brave thing, and it's not something, and it's something to be proud of, that you can actually level with yourself or your loved one to be able to get the help. Because not only do we have anecdotal evidence that treatment works, but we have scientific evidence showing that of all the modalities, therapy itself, in a meta-analysis of 10,000 studies done in 2001 at University of Wisconsin, had a efficacy rate of 0.79, which means that people that went to 10 therapy sessions or more reported that they felt better, had met their goals, and were doing better than people that had not gone to 10 therapy sessions and had the same issue. And that goes for all issues. So the efficacy rate of aspirin, I think, is like 0.2, right? That's pretty much worked for me every time. So if therapy's efficacy rate is about 0.79 or 0.8, that is off the charts. And, we will, and so we have to understand that also, there's medically assisted things and medications that can help as well, integrated into these programs. But that the therapy alone will work. The hard part is opening yourself up to it. So if you can take that first step and get on the phone, like Ray said, and jump on the internet and get yourself into some emails and some contact forms, change will occur. It just doesn't happen overnight. It doesn't happen in a mythical way. No one's going to come into your home and take your drugs and flush them. You might have a relative who's done that, but you'll just go get more. So we need to take the step ourselves. And that's the hardest part, but it is rewarding, because the long-term rewards you can't even imagine. So that's my spiel today.
Thanks, Paul.
Thank you, Paul. This has been great.
And there you have it. This has been another episode of the Intentional Clinician Podcast. If you are enjoying this show, please share it with people you know. I would surely appreciate it. Or leave us a rating on iTunes. Until next time on the Intentional Clinician, I'm wishing you all a safe and peaceful week. If you are looking for an EMDRIA consultant, I am now an EMDRIA consultant in training and can provide 15 of the 20 hours needed to become an EMDRIA certified therapist. I am going to be starting an EMDRIA consulting group, both online and in person, this fall. Check out details at Counseling Supervisor GR or healthforlifegr.com. The recording you just listened to consists of the personal opinions of Paul Krauss and his guests, and while these are based upon the literature they have read and their experience in the field, they should not be viewed as the definitive opinion on this or any other subject. Listening to this podcast is not a substitute for treatment. If you are in crisis, please dial 911 right now or the National Suicide Prevention Line 1-800-273-8255. Are you a young person of color feeling down, stressed, or overwhelmed? Text STEVE, that's STEVE, to 741-741. STEVE to 741-741, and a live, trained crisis counselor will respond to you. If you are in need of counseling, do not hesitate to make an appointment with a local counselor in your area. You can also make an appointment with the excellent clinicians in the Grand Rapids, Michigan area. They are working at Health for Life Grand Rapids and the Trauma Informed Counseling Center of Grand Rapids. Just check out www.healthforlifegr.com. That's www.healthforlifegr.com, or put into Google the Trauma Informed Counseling Center of Grand Rapids and give us a call. Thanks so much for listening. This has been Paul Krauss of The Intentional Clinician.
What you staring at? Baby, what's your problem? Don't make me come down and solve them. Reflex, gonna drive the action. Some kind of perverse attraction. Who's next? Gonna flex your muscle. Gonna shake it like a black hustle. Pay now, pray now, lay down. They don't do it hard style in your town. They say that travel broadens the mind. Maybe it takes some time now. They say you got so cool to be kind. Maybe it takes some time now. They say that travel broadens the mind. Maybe it takes some time now. They say that travel broadens the mind. Now, you know he's a regular. Yeah. He's a hard man to love. Goes straight for the jugular. Yeah. He's a hard man to love. Taking liberties because he can. Not within the purview of the modern man. Hangs his hat on spectacular. Yeah. He's a hard man to love. He's a hard man to love. Sit there, don't stare, I dare. Kinda think I know what you're feeling. Reeling, glancing, stealing. Wanna strip it from floor to ceiling. Hey now, hands down like wow. Gonna give you what for you're needing. Bleeding, reading. Now you're in a 10 for succeeding. They say that travel broadens the mind. Maybe it takes some time now. They say that all true lovers are blind. Maybe it takes some time now. They say that travel wrongs the mind. Maybe it takes some time now. I say you know you're gonna be mine. Now, you know he's a regular. Yeah. He's a hard man to love. Goes straight for the jugular. Yeah. He's a hard man to love. Taking liberties because he can. Not within the purview of the modern man. Hangs his hat on spectacular. Yeah. He's a hard man to love. He's a hard man to love. This is never easy, so I'm asking so politely. Are you ever gonna admit you like me? Turn it all around, see it in your eyes. Come and get your prize, no more alibis. This is never easy, so I'm asking so politely. Are you ever gonna admit you like me? Turn it all around, see it in your eyes. Come and get your prize, no more alibis. Staring at, baby, what's your problem? Don't make me come down and solve them. Reflex, gonna drive the action. Some kind of perverse attraction. Who's next? Gonna flex your muscle. Gonna shake it like the oobleck hustle. Pay now, pray now, lay down. They don't do it hostile in your town. They say that travel wrongs the mind. Maybe it takes some time now. They say you got so cruel to be kind. Maybe it takes some time now. They say that travel wrongs the mind. Maybe it takes some time now. They say that travel wrongs the mind. Now, you know he's a regular. Yeah. He's a hard man to love. Goes straight for the jugular. Yeah. He's a hard man to love. Taking liberties because he can. Not within the purview of the modern man. Hangs his hat on spectacular. Yeah. He's a hard man to love. 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 He's a hard man to
And it's exciting to see, Scott. You know, I know there could be some negatives about that,
Paul.
but I know. I'm sorry, Paul.
I'll edit that out. Just start with, it's exciting to see. We'll edit that. That's funny.
You know what,
Okay.
Paul, we're really excited about that.
I'm so excited I forgot your name.
As soon as I said it, I knew that. I'm sorry.